So we also have got the hall 20 minutes late. So from the Delhi Ophthalmic Society, the session starts with the first opening batsman is Dr. Maipal Sachdev talking about sir managing retained lenticules.
Thank you very much, Dr. Kirti. Retained lenticule is something that came in once we went on to the calyx or the keratolenticular extraction. So when you're looking at retained lenticule, basically it is the uncut area that is there. So you leaving behind a part of the lenticule which we called as retained. So since you are entering from a 2 millimeter incision, at times taking it out is going to be difficult. So if there are secretions, if there are any foreign bodies, lashes, etc., or there is a difficult dissection, that is the time you can have retained lenticules. And when you have a retained lenticule, the best is to dilate the patient, and you can see that on retroillumination, this is a retained lenticule. Now, retained lenticule, what does, if all of us try to take it out, but there is no harm if you kind of abort the procedure and maybe come back later. So if you look at the picture that you have, a retained lenticule, for example, at this particular point, you can see there is an elevation which you can see, and also if you see on the topography map that this is a flatter area, but this is not a flatter area which is there. So what do you do at the time? So there are several techniques. One is just doing nothing and just hydrating the whole area. Can you see this retained lenticule? This is the retained lenticule, and it's a matter of patience only that you try to find the plane again. So you can easily see that this is the area which is the retained lenticule, and this is what we are trying to take out. We have dilated the pupil a little bit, and you can see that one is able to identify once it is well hydrated. So this is then a question of going with a blunt dissector, because you can't go in and hold it and go with a sharper duckbill dissector. And you can see once you hold that, you are able to pull it out, and that is the retained lenticule. So I would just say that if you are patient enough, you should be able to get this lenticule out and then spread it and see that the half lenticule which was there, which is there. Now this has been described by Gitansha Sachdev et al., and this is the use of tricot. Even fluorescein has been described, even tricot has been described. So if you use triamcinolone like you do for vitrectomy cases, you will be able to actually visualize the retained lenticule in a much better fashion, because it will take up the triamcinolone and you will be able to take out. This has been described by Titial et al. Both of them, Manpreet and Titial, are here. So they have used the intraoperative AIOS2025-GP162-Delhi which is there. That you can do the intraoperative AIOS2025-GP162-Delhi and you can find out where the lenticule is. The other way to get onto the lenticule is to use the circle software. I'll just show you. I haven't used this, but this has been described. When you are using a circle software, you are actually converting a cap into a flap. So this is the way that you start, and you can go ahead and that you have created the cap into a flap, and you can lift it, and then obviously you can easily see where the lenticule is. Take it out. This is just for a enhancement surgery. This is not for a retained lenticule. But all that I'm trying to say is that the cap becomes a flap. You lift it as a flap, and wherever is the retained lenticule, you can then go ahead and take it out. Now, this is a case which you can again see that there are black spots at that particular point, and this is whenever the OBL doesn't form. That means that it is not dissected well, and you can see that we are going into the various planes. Once you have gone into the various planes, you can see that there is a rip here, you can see, and it's sticking on at this particular point. Once it is sticking on, you have taken it, you knew that it is a difficult dissection, you just go ahead and actually spread it. That is most important, especially for beginners. And you can see that this is the area where there is a piece of lenticule. So they go ahead, the machine has a slit, and you can see on the slit that this is the area of the retained lenticule. And then again, it's again a question of going in, identifying the plane and taking it out, and you can see that this is the piece of the retained lenticule. So the main important thing is to identify and take it out. Now this, if you see in this particular case, this is the OCT, that intraop which was described. You can see that these are black areas. So this is going to be an uncut area, And you can use the OCT. You can see that this is an uncut area. You can see the lenticule here. So once one is working on it, you can see that there is going to be the dissection, which is again not very comfortable at this area. So we are not getting the dissection done at this particular point. So again, what we have to do is that you can take a sharp duckbill kind of a separator. There you can see, and again you can work on the OCT. With the OCT, you can find out the area where it is, and you can take out the retained lenticule. Now this you can see that this has not been one has not been successful in taking out the hole, and this is the area where you can see this on the OCT. This is the lenticule which is there. So you go ahead with the OCT guided, you can see, and then separate it out, and this was the dark spot that you had, and you will be able to actually do and take out the lenticule which is there and put a bandage contact lens. So friends, just to summarize, that retained lenticule is a possibility, but once you have learned the technique and you have optimized the laser settings, normally you do not have retained lenticules. But if your cornea is dry, mind you, this is important, that if your cornea is dry, that is the time when the penetration of the femto doesn't happen. So it is better to have a slight lubrication on the cornea. Do not have any foreign body. Even an eyelash, if it is there, it can have a dark area. So the femto cannot penetrate any opacity. If it is an opacity, a pre-existing corneal opacity, or if there is a lash, etc. So be careful to say no to those cases vis-a-vis the femto. And the detection strategies, as I told you, a slit lamp examination is essential. OCT can be done. Triamcinolone, sodium fluorescein can be done to kind of stain that. You can do a circle scan, and if the retained lenticule remains, you can actually go ahead and do a topo guided treatment for that area. If it is a very small lenticule, you can let it be and it does not cause any problem. And the prevention is the best practice. So having a good dissection, if you are having too many dark spots, it's better to go and fight the war some other day. About the procedure, nothing is lost. You can go ahead and do a surface ablation or convert it into a flap maybe a couple of weeks down the line. So this is all that I wish to say as regards retained lenticule as a complication with the KLX procedure. Thank you very much for your kind attention.
Thank you, sir, for a wonderful tips and tricks of all these. Are there any questions for sir? Because he's really given a very good, for no complication for him, like any complication managed well is no complication. Thank you, sir.
Thanks.
We wish and pray that he gets his lunch.
Yeah, thank you.
ये तो सर प्लेटें यहाँ से भिजवा दें.
Sorry?
प्लेटें साथ में भिजवा देते हैं.
So, thank you, Delhi Ophthalmological Society, for
Sir,
this
Dr. Grover,
opportunity
sir.
to be a
Next.
part of this beautiful session. I'm going to talk about the difficult area of medial canthus. Trauma to medial canthus, because of its complex structures, is a nightmare, both for primary management and more so for traumatic deformities. Today, I'm going to talk about management of the post-trauma deformities. Now, the structures that are present in the region of medial canthus include the various bones, the orbital fat, the muscles, the vessels, ethmoid arteries, and the nerves, the medial canthal attachments with the help of the ligaments, and the lacrimal system. So you may have trauma involving any of these structures. But many of the deformities are caused by injuries to the medial canthal tendon. Of course, there is this lacrimal apparatus, the fat and the muscles, as we spoke about. The medial canthal tendon has a complex structure with a deep head or deep insertion and a superficial insertion. The superficial insertion is relatively easier to manage, but it is the complex posterior injuries which affect the posterior ligament, which cause the worst forms of telecanthus, which are attached behind the sac at the posterior lacrimal crest, which are more difficult to manage. So naso-orbitoethmoid fractures occur usually due to blunt trauma or as a part of panfacial trauma. Imaging helps identify the structures involved, and there are special techniques for the medial canthal region. So these injuries to the tendon which cause traumatic deformities are either those which involve the anterior or posterior crus of the medial canthal tendon, or the associated fracture with their various conformations. Now, an anterior crus injury, as I said, is relatively easy, and it can be sutured to periosteum anteriorly at the anterior lacrimal crest. But the posterior crus is more difficult to manage. You need a careful restoration with permanent sutures like Prolene in primary trauma, but in complete avulsion, you may require microplating, as we'll talk about later. So an avulsion like this can be reposed, but most cases also have a canalicular trauma, and that needs to be tackled as well. So fortunately, we are blessed with a very rich vascular supply on the face, and avulsions like this, if sutured well, give us results that are very gratifying. But when the deformities occur, they may be either due to the soft tissue injuries, which is primarily because of the ligament, or the naso-orbito-ethmoid fractures. Soft tissue deformities again require a variety of techniques, like the one that we see here, a Z-plasty. So the principle of medial canthal repositioning is restoration of the medial canthus behind the sac at the posterior lacrimal crest. So you have to identify the region behind the sac, put a suture through that, and use that permanent suture with periosteal bites or through whatever means that are required to anchor it to the medial canthal tendon. So once this is done, it is anchored to the medial canthal tendon, and then the restoration of the medial canthus is done, restoring the right position. So this is an example of a posterior fixation of medial canthal tendon, which combined use of a Y to V plasty in order to reposition the medial canthus. So you can see a medial canthus which is grossly displaced being put back in position, and the depth being restored. When there is a downward displacement like this, it is best to do a Z-plasty or a Z-plasty in order to get the canthus to reposition, taking the medial canthus in the lower limb and then transferring it upwards in order to get a much better position of the canthus, as you can see here. So this is an example of a beer injury with a forehead scar with a traumatic telecanthus, anteriorly displaced canthus, where we decided to do a scar revision, repositioning of the medial canthus deeply, and at the same time taking care of the scar. So this is how it looks from this anteriorly displaced canthus to a corrected telecanthus, and the scar has been repositioned. The brow, which was malpositioned, has been put back in position. The bony deformities require a different kind of strategy. You often need to refracture, realign, sometimes do a bone graft. So this is an example of a bone graft and nasal wiring. Other internal fixation techniques, the most preferred one is low profile mini plates, which we often use. Plates like these are anchored to the posterior lacrimal crest, one of these holes being used with a Prolene thread to anchor it to medial canthus. So an example is this kind of a patient where we'll do a Y to B plasty along with the medial canthal repositioning using a mini plate made of titanium fixed with screws. So this is a double hole titanium plate where we are fixing it with self-drilling screws. Generally, short screws only can be fixed here. The other eye has 40 Prolene suture, which is then passed through the medial canthal tendon, and once this is realigned, it gives you a dramatically improved position, as you can see here. This grossly displaced medial canthus can be repositioned. This is the example of an early post-op appearance, pre and post-op appearance, where you have a gross deformity, you are able to improve it, and then day one, this is what you see, and when you have done the ptosis correction as well, you can restore this to a much better position. So when you have a bilateral one like this, transnasal wiring is often the answer. She had a bilateral nasolacrimal duct obstruction as well. So we did an open sky DCR and transnasal wiring. We could really transform her life with much improved lid position. You can see how it would change her life forever. So thank you for this opportunity again. The traumatic deformities of medial canthus are a tough problem, but with perseverance and with proper technique, they can all be tackled. Thank you.
So, Professor Tityal is the next speaker, and then I'll go
Thank you
next.
so
and
much for a wonderful presentation, sir.
Good.
Such complicated cases made so simple.
Dr.
and
Grover's
so thank
surgery
you, sir.
always is a treat to watch, sir. The bloodless and super clean.
Edited versions are bloodless.
Sir, इतना blood तो नहीं दिखता वैसे भी.
And thank you
Very
for
clean
letting me
surgery.
speak first, both Dr. Tial and the chairs.
So, can I request the President DOS and the Secretary DOS to take their rightful chairs?
Good afternoon, friends, and thank you, the DOS executive, for a kind invitation. Dr. Rohit and Dr. Parfulla Marana, Kirti, Dr. Professor Kirti, and chairpersons, Dr. Sarita and Dr. Rahul. I think DOS representing in AIOS APO meeting is a huge, thing for all of us. Has the magnanimous history for our past, doing so well. Let's hope DOS meetings also do well in subsequent time also. And both Rohit and Prafulla has to do a lot of work to have good meeting happening, which is going to happen very soon. I think after Dr. Mahipal talked about the complications, management of refractive procedure on the cornea, I'm going to take you through the cataract surgery which is required to be done in a post-refractive surgery eyes. And definitely it gives you some sort of challenges to perform better and do it in such a manner that patient's outcome improve. If you see the entire journey, evolution of refractive procedures, the lasers which have been applied to cornea or the lenticular-based surgeries, right from the early 1900 to now 2024-25, nothing has changed except for the incisional refractive surgery on the cornea have become past. But we still see those cases, and they are the most challenging cases for not only for performing cataract, but giving the best outcome of these patients also. So these are various procedures, various percentage of complication we can see. But today I am concerned for you is a cataract which happens in these cases. And it is not very significant number of patients will have cataract in the initial phase. Once they cross 40 years of age, then they definitely have cataract formation, especially high myopic patients when nuclear sclerosis may be a challenge in these cases also. For any cataract surgery, you need to do a good analysis for these patients. I would understand specular microscopy must be done for all these cases. Assessment of a fellow eye is also important. Look for any other associated problems which may be challenging for cataract surgery, like intumescent cataract, hard cataract, small pupil, other associated problems. But most importantly, look for a corneal health. That is the wavefront analysis of cornea to rule out irregular astigmatism. Higher order aberration has to be seen in these cases also, because that is the one area which cannot be corrected by cataract surgery. So if that is so, then things become difficult. So let me take you to a few of my cases where I can explain how effectively we have done surgery for these cases. So this young lady was undergone radial keratotomy almost 25 years ago when she was hardly 26 or so, and presented with a diminished vision and cataract in the right eye. If you see, patient did have a large amount of cylinder. You can see this is almost 2.93 diameter cylinder. And should we put toric or not, that's a consideration. If you see all patient RK, the first question will come, why premium IOL? Do you think that's going to work or not? Therefore, I think the IOL power calculation And to select the best formula is a challenge for all these cases. And which type of IOL should be implanted. And third is important, that's the most important part, is the counseling for these patients. Because these are patients, they are mentally for, some sort of freedom from glasses. That's why they undergone refractive procedure when they were young. And at this stage also, they want a similar outcome in these cases, which is very difficult to give. So this is what we have done for this patient. Apart from the examination, we looked into a wavefront profile of this cornea. If you see this, there are hardly any, aberrations, higher-order aberration, trefoil, coma in this particular eye. And the entire MTF values, point spread function is quite good in these cases. You can see the corneal health is quite okay, and hardly less than 0.4 is the HOA in this patient, good MTF and PSF. If you have this, that means you have ruled out the corneal irregularity in this patient, and this is a good cornea. Therefore, you might have to give them a brighter option of correcting this high cylinder and good outcome. Today's generation formula like Barrett True K is one of the best formula for all post-refractive surgery patients. That includes post-RK patients also. I've been using Haigis for a very, very long time with a good outcome. Now shifted totally to Barrett True K formula for these patients also. So this is a patient who has more than 12 incisions. Just see, it is a posterior limbal incision, and the side ports are also posterior limbar. The blood is coming, and that is important because some of the RK incision may be, trans limbus also, and they are almost 90 to 96% depth. So you should be a little careful managing these cases also. If you are sitting superior side, you might do a flap and go little, scleral tunnel, which is safeguarding the incisions. Rest of the surgery is as normal as you routinely do in these cases. Good hydrodelineation, rotation, and you can do a phaco easily in this patient. Only thing, sometimes the AC may be deep in these cases. Therefore, your phaco parameter has to be adjusted accordingly. Do a multiple chops. The nuclear, you may have a very bright glow, but nucleus may be still harder. So that you have to understand, and maybe a chop has to be done properly, and eat out the entire nucleus within the possible nuclear bag. Take out the epicortical cushion which you safeguarded, and aspirate the cortical fibers. Here you have to be very, very careful not to leave any fibers on the both anterior and posterior capsule which is there, so that PCO formation decreases. Because all these patients, myopic patients, do have a higher chances of a PCO happening in these patients also. Implantation IOL also very important, should be hydrophobic. If possible, a lens which has a stability in terms of toric lens. This is the Technics 2 variety of toric IOL, which has quite a significant stability intraoperatively in a posterior period also, compared to Technics 1 design and other lenses. And towards the end, this I'm hydrating here, but better is to put a suture here, which I'll do here, because if you hydrate too much, you can split the arc incisions. So main wound should always be sutured, and the analysis should be done 1 week post-op. If needed, you can remove the suture, and you can see what's the vision in this patient. You can see a clear cornea, good glow, and 6/9 vision day 1. And I remove suture in these cases after 7 days to 10 days. The second is phakic IOLs, but these are patients who are actually high myopes, and they have a high chances of a cataract formation. We have taken the series of cases with a femtosecond laser application in these patients with the advantage of a closed chamber technique without disruption of pupil size, because if you take out the ICL first, sometimes pupil constricts and things become difficult. So this is what we have done in these cases, doing a femtosecond laser application. You can see this is a 4.8 millimeter sizing of anterior capsulotomy and 8 incisions. Because of ICL there, the gas bubble doesn't escape, and it can form the thick bubbles there, and you may have a skip areas in these cases also. And you have to be sure that this ICL is not taken as anterior capsule. So manually you have to shift your parameter up to the anterior capsule in these cases also. So this is the same patient, one of the first patients where I've done femtosecond laser under the ICL now. I have a good dilatation. You have a capsulotomy and lens fragmentation. ICL can be easily now explanted through 2.8 millimeter or 2.6 millimeter incision, and that's very, very simple. And subsequent surgery also is almost simpler in these cases. To remove the free floating and do a nucleus removal, implant the IOL, and patient really does well. The femtosecond laser does have an advantage in these cases also, This is the patient post-op, had a 6 and 6 vision. In fact, I implanted trifocal lens for this patient. This is another group of patient. I should do a lot of very sized lenses in early 2000. This patient had a multiple, disinclination. I had to do multiple surgeries. You can see the superior side is still one suture is there. Entire limbal stem cell deficiency is there. You can see conjunctivalization. You can see AC depth is quite good. Now I can use this superior area to take out this lens, which is 6 millimeter. So I have to do a small incision surgery first, then take out the this very sized lens. The idea is to disinclinate the area where I'm going to do phaco from here. And this you can see a space from anterior capsule to the lens. So I'm just detaching this area and shift this lens towards the inferior side for a manipulation. Because of multiple attacks of uveitis, the pupil has constricted, so we have to enlarge the pupillary size. I've used multiple hooks. Normally I use 6 hooks to have a very nice, gentle stretch of pupil hexagonal shape. Then stain the anterior capsule and do a subsequent procedure. I've done a rexus now. And now once rexus is done, I'll complete my phaco procedure now. Hydrodelineation has been done. Entire thing is done. I'll show that this particular lens, because it is fixed here, doesn't really move during the phaco procedure and doesn't hit the endothelium. And that is the beauty of this one-sided inclination and shifting the lens. In fact, this is protecting the fluid wave to go towards the endothelial side. So this is a very good concept of doing small incision phaco surgery. You can see the space from endothelium to this very sized lens is quite significant, not getting towards the endothelium at all. So you can do a surgery now after completion of this. This is a high myopic patient. I'm putting the expand series of lens inside. So once I implant this lens, then I'll disinclinate this and take out the lens after enlarging the incision to a 5.5 millimeter. So effectively, I use this one site incision for doing both the procedure, phaco, as well as for taking out this very sized lens effectively without causing a disruption, damaging this area which is already damaged by multiple surgeries. The outcome is quite good. To summarize, all cases of refractive surgery are challenging. As I said, counseling should be a primary importance for us. The pre-surgery counseling will decrease the post-surgery counseling, time for you, and do a good surgical technique. If you have femtosecond laser, use that for your advantage. Always look for a corneal topography and wavefront assessment of cornea. Then choose the IOL as such, which corrects the entire area. If needed, you can always take this patient for secondary procedure to take away the remaining hyaluron ablation by doing a topo-guided ablations. And that also does quite well in these cases also. So effectively, good surgery, good outcome in these patients can be seen with doing a good procedure as such. Thank you, DOS, for giving this opportunity, and wish DOS great success in the future.
Thank you, Professor Tityal. That was a wonderful presentation, and of course, your unique way of showing how complicated surgery can be made easy. So I'll request our secretary, Dr. Praful, to invite the next speaker, please.
Thank you so much, sir, and thank you for your best wishes for DOS, which we know is always there with us. And next, I'm going to invite one special person from DOS, Professor Kirti Singh, ma'am. And ma'am is an excellent glaucoma surgeon and most importantly an excellent teacher. So ma'am is going to speak about malignant glaucoma, different strokes. Welcome, ma'am.
Thank you so much for your kind words. So I'll be talking about malignant glaucoma, some different strokes which we faced which caused diagnostic dilemmas. So we do know that malignant glaucoma described by von Greffe incidentally 1869 or the aqueous misdirection has elevated IOP despite more than one patent PIs as a definition. It is usually, it can be spontaneous, but it is invariably after incisional surgery. It could be cataract, glaucoma, pars plana vitrectomy, buckling, YAG PI, sutural lysis, or post-biotic use. And out of these, the predisposing factors are Asian ethnicity, females, ACG, short axil length, and fellow eyes. And by chance, the two cases I'll be showing will have all these propensities, but with a difference. So the case one was a 29-year-old male student. He complained of decreased vision for distance and near in the right eye. Left eye already he had lost vision for a year. He had consulted elsewhere who diagnosed glaucoma and started on medicines. He was on 2 anti-glaucoma medications. He had a positive family history in the grandmother who had glaucoma. Now, when we saw the patient, we thought this was a juvenile open-angle glaucoma because 29-year-old. Incidentally, I don't know how many of you we are seeing early onset angle closure glaucoma now. So this was another one of that child who had angle closure glaucoma and the poor vision with definite pupil rough atrophy with the patent PIs and shallow anterior chamber. The pressures were very high at 34 and 32 despite medical management, and so he was taken up further, and the gonioscopy confirmed the closed angles with goniosynechia. The disc size was average sized with a DDLS of 7 to 8 and a cupping of 0.9. The right eye had a macular split, and the left eye, the vision was so poor that the fields could not be done. So we planned treatment on the sequential trabeculectomy was planned. Oral AGMs was started. Now on first week post-op, he complained again of decreased vision. Now this was the only seeing eye he was dependent on. So he complained of sudden decreased vision again. The vision had dropped to hand movements. The bleb was not overfiltering, but the AC was diffusely shallow. PI was patent and the lens was bulging. But the IOP was very low at 4 millimeters of mercury, literally not regardable. So we looked out for coral attachment. It wasn't there. On the UBM, there was no ciliary wall rotation evident, and B-scan confirmed that there was no CDs. So there was a diagnostic dilemma, and we found to our surprise that there were hypertonous malignant glaucoma described. So that is what we diagnosed, and surprisingly, the other eye, which had the surgery done later, after releasable suture removal, again that eye also had a shallow AC. But here the IOP remained high, and here the UBM did show ciliary rotation. So the diagnosis of malignant glaucoma hypertonus in one eye and malignant glaucoma hypertonus in the other eye. So as the treatment described has been cycloplegics and YAG laser and Chandler, we did the same things. We did cycloplegics and topical steroids. We did the AC reformation with viscoelastic. We went by the book, and then we did the Chandler's procedure. After that, the treatment worked, the vision came back, AC became formed, and the pressures increased to 10 millimeters. On the follow-up, since he required atroponization, this patient couldn't see his mobile phone or anything, so he stopped using atropine. And because of the stopping of atropine, again the pressures came to 14, but the AC shallowed and the vision dropped. So we have two eyes, one behaving with hypertonous malignant glaucoma and the other hypertensive malignant glaucoma. Now over a 2.5 year follow-up, the bleb is maintained, but the patient requires atropine. We are trying to convince him for a lens extraction, but he's not being convinced. So the second case is a 75-year-old female. She had advanced PACG again. Right eye, a trab had been done 10 years ago, and left eye, a phaco trab had been done. She had significant cataract, so we took her up for a phaco, which was uneventful. After 3 months, she came with recurrent episodes of shallow AC and IOP spikes, and the presenting feature was not pain, the presenting feature was myopia. She was treated with atroponization, and again we did the whole Chandler's procedure, everything, but here nothing worked. And after the 4th episode, the bleb was shallow, the PI was updrawn regarding needling. We did a YAG hyaldotomy and a capsulotomy. Then we went ahead and thought that we'll do a pars plana vitrectomy. So it worked for a couple of weeks, but then again the myopia and the shallow AC occurred. So ultimately, finally, we did an iodozoinlo hyalodovitrectomy, and since then she has been fine, and this patient did not require atroponization. So IZHB was the solution, and the other eye which had the phaco trab done has been stable since 2014. So again, we have two different manifestations in two different eyes. So to summarize, variable presentations of aqueous misdirection, angle closure is a known risk factor. One was a young boy with normal IOP, and the fellow eye was high IOP. One was an elderly lady with multiple episodes of high IOP with a presenting feature of myopia and shallow AC. The triggers were trabeculectomy, cataract surgery, and releasable suture removal. Lessons learned was that IOP could be a confounding factor. Sequential management strategy works in most. Fellow eye is predisposed, and recalcitrant traces do require IZHV, and lifelong cycloplegia may be needed. So we leave you with this message of nature, which looks like a question mark to me at least, that the malignant glaucoma is still manifests in different ways, and this was one of the third cases reported. We sent it for publication of hypotonous malignant glaucoma. Thank you.
Thank you, Dr. Kirti. I think it is, you really presented it very well, and this, all these complicated cases which you managed so well. Thank you so much. Now we call upon our next speaker.
Yeah, I'll call upon Dr. Rohit Saxena, sir, President DOS, for his next talk on managing raised intraocular pressures.
Cranial.
Cranial pressure, sorry.
We just had a talk on intraocular pressure.
Sorry,
I think we are
I'm
overwhelmed by
impressed
the
by your
glaucoma that Dr. Kirti just presented, and thank you, of course. So while my slides get on, thank you everybody for coming for this DOS session. We as the host welcome everybody to Delhi for the APAO, and of course thank you very much for coming for this session that we are having today. It was a mixture of everything. We wanted to showcase some of the different surgeries and the different procedures that we do, and I'm proud to say that our surgeons are among the best in the world, what to say of India. So I'm glad we got the opportunity to showcase the work that our leading Delhi ophthalmologists do. So I'll just be presenting a little different topic, which many of you do not get a chance to see or talk about. So this is about raised intracranial pressure and how we can manage that, and I do not have any financial interests. So I'll just talk about this case, and this entire discussion will be based on this case. This was a 30-year-old female who came to us with progressive loss of vision, both eyes, simultaneous. She had prior history of transient obscurations of vision associated with headache. The history she gave us was that her vision had improved intermittently every time she had a lumbar puncture done or a CSF tap was done, and which had demonstrated high pressures, but transiently she would get a little better. But she, while being on on full acetazolamide, she could tolerate. Her vision continued to be very poor. So she was hand movements, both eyes. Motility was normal. We do see sometimes some abduction deficits. She was definitely heavily overweight with a BMI of 40. And other than this, there was no other neurological problem. So this was her fundus. You can see virtually atrophic discs. You can see a small splinter hemorrhage, sign of some amount of edema. We did, it's normally not necessary to do a fluorescein angiography, but we just wanted to document a little bit of edema, if any, and whether any other intervention is going to actually help. So you can see a small leak that was there in the left eye. The right eye was absolutely atrophic. You couldn't see any leak of the disc also. You could see the VER flash pattern was not possible. The VER flash showed a small tendency of a waveform, which is what we use just to take a call. So the basic interest to work this patient up like this was to know whether any surgical intervention is going to impact her visual functions or not. And that was our key area. Of course, part of a routine workup for the diagnosis of IAH and MRI was done, head and orbits, and you can see the thickened optic nerve sheath and that small atrophic optic nerves in the middle. So this is the donut sign, which you can see the thickened sheath with a lot of fluid. So we knew that there is a lot of edema fluid that is in the sheath around the optic nerves. And well, the thought was, let's give her a chance because she was not doing so well medically. So this is a procedure of showing you how an optic nerve sheath fenestration is done. The aim is to reduce the pressure around the optic nerve. The alternative to this is a shunt. We'll discuss that, but because the vision loss was the primary complaint and she was coming to us with severe visual loss, we thought that we'll give the optic nerve sheath fenestration, a less invasive and traumatic procedure compared to shunt surgery, a chance. So this is how we go ahead. This is conventionally just the way you do squint surgery. This is medial rectus was identified, isolated, sutures were passed, and the muscle was disinserted. So till now, this is the conventional surgical procedure you would do for, say, recession of any rectus muscle. So 6-cervical suture, disinsert the muscle. This is the medial rectus, so you disinsert the muscle, and then our approach is to now abduct the eye. So these are traction sutures, Ethibond or any suture you can use to create a traction and get the globe to be abducted so that you can approach the medial side of the eye. So these are traction sutures so that you can pull the eye away. The disinserted muscle is now posteriorly pushed. This is a malleable retractor for the orbital surgery. And after you retracted and separated the fat, you can see this is the optic nerve, and what we are separating or pushing away are the long posterior ciliary arteries and vessels. So that's what we are doing, and you can see the distended sheath, and we use a straightened keratome to make an opening, and you can see the fluid that has come out. So that's all the CSF fluid that has drained from the perioptic space. It's better to make a flap so that it remains permanent rather than just a split or an opening. So the flap is removed and a permanent window has been created, and subsequently you can just remove all these and resuture the muscle back and close the conjunctiva. So the rest is just like any conventional, again, strabismus surgery where the muscle is now replaced to its original position. So this was just to describe you or show to you the optic nerve sheath fenestration procedure, and we'll show you how the results performed in this patient. So day 3, her vision improved from finger counting to 1/60. Day 21, by the 3rd week, she had improved to 6/18. She was on 2 tabs acetazolamide 4 times a day. For the initial 3 weeks, we generally tend to keep them off any acetazolamide because we would want to keep that opening there. The CSF will drain from that opening and prevent any fibrosis or any fat from obstructing the opening. If we start Diamox very early, then sometimes if the fluid is less, then you can have an obstruction or closure of that opening. So the aim was, so this vision significantly improved just on basis of the opening of one eye. So the other thing again that we realize that you do not need to operate the other eye. You can just operate on one of the eyes, and the improvement is in both the eyes, and therefore actually we tend to operate the poorer or the worse prognosis eye so that we can get a benefit on both the eyes. You can see now we can have a certain central field that is recovered and the patient is actually ambulatory. You can see the improvement in the waveforms of the visual evoked responses. So the management of raised intracranial pressure is to check the visual functions. Headache, prefer to refer them to the neurosurgeon for a shunt procedure. If the vision is the clearly more important function that is being affected, start with medical management, follow up the patient. If it worsens or if there is no significant improvement, think of a surgical intervention. And again, if the vision is the primary problem, think in terms of an optic nerve sheath fenestration. Of course, before you do anything like that, stop any drug, identify the cause. Sometimes, of course, weight is something that is very important. Control anemia, blood pressure, CPAP for obstructive airway disease. These are the medications that have been tried. Acetazolamide is the sheet anchor for therapy. Topiramate and diuretics have a very small incremental effect over acetazolamide, but anything helps sometimes in these. Many of us who've who've handled or managed to or attempted to battle the war on the bulge appreciate that how difficult it is to do weight reduction, and there is but adequate proof that weight reduction has a very significant effect on visual functions and management of IIH. So it's something that you must advise because it does make a major difference to not only spontaneously improving visual functions, but also having a long-term impact on outcomes. So these are the surgical options. We, of course, do optic nerve sheath fenestration. Neurosurgeons are referred to if there is severe headache or very, very high CSF pressure. So if it's a fulminant IIH, obviously a shunt would be better than just a small optic nerve sheath fenestration. So the aim is to reduce the pressures around the optic nerve and Of course, you would follow up with entire visual functions. There is a risk of early vision loss. You're operating right next to the optic nerve. So sometimes if the vision is good to start off with, you may have a risk of failure of the surgery or vision loss. But usually you tend to have less likely. So confirm IAH, make possible all medical interventions, and if required, do an optic nerve sheath fenestration. Thank you very much for the opportunity.
I think excellent presentation, sir. I've never seen an optic nerve head fenestration before.
I
It was
think
wonderful.
It is the most complicated surgery on an optic nerve. I think an eye surgeon would have never operated on an optic nerve as such,
I have
like
never
this,
seen such a
on optic nerve sheath.
So that is why I thought it would be prudent to show, surgeons the fact that optic nerve surgeries.
So
are
after
there.
this heroic surgery, we will listen to the heroic surgeon, the hero of diabetic retinopathy, Dr. Cyrus Shroff. He needs no introduction, and this is the most complicated surgery in retina, which he'll be showing us how easy it is to do this and the tips and tricks on it.
Thank you, Dr. Sarita, for the kind words, and thanks, DOS, for having me over for this nice session. We've been learning so much from every talk we heard so far. So the next few minutes, and this will be in the form of a video. ये कहाँ है? या मैंने कल लोड तो किया था.
I can see the next session speakers are here. I'm sorry we got the hall very late. There were some initial glitches in the previous program, so you'll have to bear with us for two more talks, Dr. Cyrus and Dr. Prafulla, and then we'll hand over the hall to you. Thank you. सर का लगा दो, या तो तब तक डॉक्टर प्रफुल्ला का कॉल कर लें क्या? प्रफुल्ला तुम्हारा कर लो सर का, तब तक. ओके. हाँ, वो उधर लोड हो जाएगा सर, अभी करा देते हैं. हाँ, डायरेक्ट लगा दो. अगर लगा दो तो अच्छे. वीडियोस एक्चुअली थोड़े स्लो हो जाते हैं ना ट्रांसफ़र करते हुए.
ऑडियो भी है इसमें. ऑडियो है.
and the vitreoretinal interface, which can assume
ठीक था.
Proliferative diabetic retinopathy is an important indication for pars plana vitrectomy. The complex cases can be very challenging To operate safely and efficiently on these eyes, a thorough knowledge of the pathoanatomy of PDR is essential. This enables the surgeon to make an accurate intraoperative assessment of the changes at the vitreoretinal interface, which can assume several configurations and achieve complete relief of traction on the retina with the least possible complications.
So
This
we'll see
short
how
clip
finding
shows
the
what
plane is
looks
the
like an
vital
apparently
thing.
simple induction of posterior vitreous detachment in a case of PDR.
This sort of simple induction would be very uncommon. So
However, closer examination reveals another layer over the posterior pole, which is being removed after creating an edge. It is important to be aware of and suspect this second layer, and demonstration with high quality 3D animations can be an important educational tool towards this goal. The animation here depicts new vessels developing at the vitreoretinal interface and progressing to formation of fibrovascular sheets. At times, these sheets can extend very anteriorly and make surgery more challenging, as we will see in a subsequent video. This animation shows a highly magnified view of changes in the vitreous cortex after a bleed from new vessels.
So this sort of splits the vitreous cortex
Bleed
into an
in this
anterior
case
and posterior
splits
leaf.
the vitreous cortex into an anterior and posterior leaf, producing a vitreoschissus cavity. In a zoomed out view, we can see the adherent unsplit vitreous cortex with the adjacent schissus cavities. The fibrous element of the anterior leaf of vitreous cortex contracts, producing a traction retinal detachment. The posterior leaf of vitreous cortex remains attached to the retina. We now see this localized traction retinal detachment in the frontal view, and in its extreme form, this can produce a large tabletop traction retinal detachment. Centripetal contraction of the unsplit vitreous cortex can cause folds in the underlying retina. The single most important step in membrane surgery is to identify the posterior leaf of vitreous cortex, and if it is attached, create an edge and a flap of that before proceeding with dissection. This is a case of long-standing vitreous hemorrhage. The classical can opener appears to be through the posterior hyaloid face, but the subsequent wave of separation shows this second layer to be the posterior leaf of the vitreous cortex. This gives us the correct plane of dissection for removal of the adherent membrane over the posterior pole. In this case, we see an anterior extension of the membrane. It is important to separate the entire vitreous cortex peripheral to this. Here, this is being done with the 25 gauge vitreous cutter. The small gauge and controlled suction and cutting enable us to get into the correct plane, after which the dissection proceeds with relative ease. Here we see how easily one can start dissecting in the wrong plane.
This was the
The
wrong
sheen
plane
on
which
the
we were
retinal
initially in.
surface, peripheral to the site of dissection, and the
And
traction of the forceps lifting
you
up
see
the
this tissue
posterior
here.
leaf of vitreous cortex alerts us to this. Now we enter the correct plane, and the dissection is quick, precise, and atraumatic. Scissors are used for blunt dissection where the attachments are fine, and cutting when a strong attachment is encountered. For bimanual dissection, forceps and scissors are most commonly used, but forceps cutter or cutter and scissors can also be employed. We generally prefer outside-in delamination. especially for the superior and lateral parts of the membrane, as this gives a better view of the connections between the membrane and retina, and consequently less bleeding and iatrogenic breaks. However, one needs to be flexible to do the best in a given situation. Apparently simpler looking cases can be extremely tricky and tough. In this case, despite repeated attempts, it was not possible to separate the hyaloid from the retina in the periphery. The posterior hyaloid face was then incised over an area of subhyaloid blood, and hyaloid separation extended around the disc and posterior pole with forceps and cutter. We could extend the separation radially in the lower nasal quadrant and then move circumferentially, superiorly and inferiorly peripheral to the fibrovascular membrane. When possible, we can segment the membrane to avoid too much traction on the retina during the separation. The posterior hyaloid was now separated temporally, and we can see parts of the membrane which were not very adherent also getting peeled off the retina. Finally, the superior extension was disconnected from the periphery and the rest of the membrane was delaminated bimanually. Surgery concluded with fluid air exchange, laser and C3F8 gas flush. In diabetic TRDs, gas and not oil is our preferred mode of tamponade.
Thank you for your attention.
Thank you, sir, for so beautiful animations and how to really teach. It's really wonderful. Thank you so much, sir.
I think it's always great to see Sir operate. We've been blessed to have him with us to mentor us. So I think hats off, sir. Very nice, sir.
Thank you. Thanks a lot. Is that correct?
Now we call upon our the DOS itself, the secretary.
Good afternoon
Prafulla.
all. So I'll try to keep it as short as possible. So here I'm going to share with you our experience of handling 6 cases which were referred to us with a diagnosis of chronic angle closure glaucoma with corneal decompensation from our glaucoma clinic. Now this were the cases, one of the cases CP is here. You can see it's very easy to get confused because there is you can see here the iris is atrophied, there are few patches of pus and the cornea is edematous and the pupil is even fixed and mid-dilated. But if you observe carefully, you can see there was some synechia was there, and this patchy atrophy is classical of herpetic keratouveitis. And if you observe carefully, there are few decimal folds also. So all these points clearly suggest that yes, you are dealing with a case of herpetic keratouveitis rather than PSEG. Similarly, this was another patient. You can see clear case of endothelial folds with epithelial hypertrophy due to recurrent corneal edema. So how to manage such cases? Now I'll just show 3 videos. So the best technique is probably DMEC. Why? Because most of these cases are young patients and they do have a phakic and you have to do a phakic procedure. And DMEC in phakic eye is quite easy if you understand the aqueous dynamics. Then with the lens in place, it's very easy to unroll the graft. So this is the standard DMEC procedure I am doing. It was a 38-year-old male patient with recurrent keratouveitis. And I did a DMEC in this patient. The important point is you have to achieve pupillary constriction, and no matter what maneuver you are doing, you have to bypass this pupillary plane. Don't go through this plane or else you may hit the lens. Then the standard DMEC was done, decimal scoring is done, and this is the 9 mm ring mark which I have put. This is one of my early DMECs, so I used to do all the steps as described by experts in the field. So once you're, and this decimal scoring is done under Helon. If it is a pseudophakic patient, you can still do it with under air, but you're not doing in a phakic patient, it has to be under Helon cover or else may hit the lens. PI is a must because these are phakic patients. And this is once you have scored, then you can take out the Hilon with the IA probe. And this is the Alcon D cartridge. There are several cartridges in market available, but you can easily convert your Alcon D cartridge or any oil cartridge simply by connecting to the IV line and using that. And this is a 2.2 D cartridge, so I can inject my graft even with a 2.2 inches in size, and I just need one suture. At times you can leave it sutureless also. Now faking cases, the DMAC is not that difficult, just a 2-3 minutes maneuver, and you can easily achieve a unrolling of the graft. The only thing is, only thing you have to remember that don't collapse the AC too much, that you may hit the interlens capsule. If you hit the interlens capsule, then the lens is going to be cataractous very soon. So this is one case, but not all cases are that easy. This is the follow-up of the patient, and this one suture, the patient never allows me to remove it because he has gone through Google Baba and he understands that any corneal trauma can incite a recurrence of your endothelitis or keratitis, so he doesn't want me to touch his eyes. So this is a second case. Here you can see the edema is little bit severe. So here in this patient's DMAC can be done, but you can see the visibility is not that good. So in such cases, I would prefer to go for a DSEC, which is more predictable for me. And as you can see here, most of the steps are same. Only thing is, I would go for a corneocerebral tunnel here, okay, because so that I don't induce much astigmatism, and I prefer a automated graft preparation, as you can see here. So again the same precautions, don't cross your pupillary area, achieve pupillary constriction, and do a PI in all your cases, and ensure that you have removed all the Desmet tag. And this is the graft, this is the Bushin glide. I use a push and pull technique by Bushin glide and a microvitretinal forceps. And again DSEC is not, and probably this is one scenario where DSEC is challenging than your DMAC. Why? Because in DSEC there is a definite stroma component. So the space, antechamber space where you are going to manipulate is very less when you are doing a DSEC in a phakic patient compared to doing DMAC in a phakic patient. So this is little bit challenging in such patients. Otherwise rest of the steps usually they goes fine. No issues with that. And last is extreme of cases where the patient had cataract, also corneal opacity and corneal edema. However, it was eccentric opacity, so I thought let's go ahead with a endothelial keratoplasty procedure. Again, I won't prefer DMAC in such patients because it will be quite challenging. Main challenge in this patient is doing phaco. So whenever there is corneal edema, few things you should take precautions. Use a viscoelastic, that will give you a temporary improvement in magnification. Use Trypan blue in all your cases. Use Rexis forceps. Start from a clear area and then complete your Rexis. Never ever start from here. And during phacoemulsification, there is a technique called phaco in situ. That means as you are dividing the pieces, keep on emulsifying them. Don't wait to make 8 pieces and then start taking emulsifying one by one. So and when you are dividing, then emulsify that piece so that you can rotate and bring all your nucleus material into the clearer area, which is in this case you can see here. So that is my operating area. Once your phacoemulsification is done, then you can always put a IOL and then complete your procedure. So few things to remove, few things that we understood from this from these 6 patients is that almost all patients are pre-cataract stage. So you have to tell them, as per the recent literature, whenever you do a endothelial keratoplasty procedure, the chances of getting cataract increases by 7%. So they may get senile cataract little early. Intraoperatively, you have to avoid lens trauma and pupillar area, do a PI. Post-operatively, steroid and acyclovir prophylaxis. But surprisingly, none of these cases have ever recurred. And one of the cause could be, as per the recent pathogenesis, virus stays in your endothelium probably. And once you are replacing the endothelium, that probably leads to a reduced recurrency. However, this has to be proved in future studies. With this, I will conclude here. Thank you so much.
Thank you, Dr. Praful. Wonderful videos and wonderful information. Thank you. We come to the end of our session, and
thank you. Can we have the speakers and the panelists for a photograph while we hand over, and the next session can start? We can just have a quick photograph up front. Audience is the panel.